Hi everyone, welcome back to Uplifting Psych NP. My name is Mia and I'm a Psych NP, and today I wanted to continue on with the series. I realized the first episode when we started to talk about medication, it seemed to cut off before I got on all my key points in, so I do apologize about that, but I want to kind of go back into that. So let's review again some of the things that we talked about, and I want to break it down and make it simple as possible with real world tips. We can talk about case-based learning and must-know resources that'll help you along the way and help you prescribe more confidently. So let's get started. In the last video, I did make you aware of like the psychopharmacology. We want to make it simple. You do not, I repeat again, you do not need to memorize every psych med there is. Just understand how it works, and here's a quick guide. So again, antidepressants, just think of this as a reinforcement of information that was received last time. So antidepressants is the first line of treatment for depression and anxiety when it comes to medication. Essentially, you can kind of think the first line of treatment, usually, in my opinion, everybody's opinion is different, is therapy. For me, I feel like therapy is the way to go. It's the least restrictive. But again, if they're coming to you for medication management, the first line of treatment is antidepressants. Because they target, it's like a 2-for-1 most times. They target depression and anxiety. So you're looking at your SSRIs, your SNRIs in that situation. Antipsychotics. We use that for schizophrenia, bipolar. Sometimes we use it as an adjunct medication for other medical concerns, so keep that in mind as well. But again, we're at the basics, and this is just a reminder of what I said last time. So with the antipsychotic class, know that there's typical versus atypical, okay? Mood stabilizers. We're using that for bipolar disorder. We can also be using that for other things as well, but for bipolar disorder, maybe schizophrenia, some of the key medications, the three medications that are really popular, and one is considered gold standard, is lithium, Depakote, and Lamictal. Know with those medications, although lithium seems to be the gold standard, it does take it does take you having a patient that is going to be adherent to lab work for that to be something safe for them to be on, for them to be willing to go out and have lab work done, to ensure that they're on a therapeutic dose. Depakote level also takes lab work as well. Lamictal, a key thing if you know nothing else about it, you want to start very small, very slow with it, and increase it because you want to watch out for a rash. That's the biggest thing with, if you take nothing away from the thought of Lamictal, remember Lamictal, a rare side effect but can happen is a rash all over your body, like Stevens-Johnson syndrome. Anxiolytics for anxiety. So some people use benzos, some people use non-benzos for anxiolytic or anxiety states. What I will say with that, again, like I said in the previous video, you want to use any benzo such as Xanax, Ativan, Klonopin, Valium, anything like that, very cautiously. And another key thing is usually research shows that long-term use of that is associated with memory loss, possible dementia, cognitive impairment, and increased risk for CNS depressant, like increased risk for possibly overdosing depending on your patient. So you have to be very open with your patient, very transparent, and give the education that's needed. And so important, whatever med you choose, you're documenting that you educated the member on that. And you want it to be for short-term use usually. Sometimes it doesn't always happen like that because we're not in a perfect world where people are like, hey, I feel great and I don't need that anymore. But it's important to know the population you're working with. It's important to know what the treatment goals are, and also have on deck, other treatment modalities aside from medication, especially when you're doing something like prescribing like a benzodiazepine, because at some point you do want them to get off of it, and they may need therapy associated with that to feel confident enough to come down from that medication. Another medication that is big, and people have, different providers have their different thoughts about it, ADHD medications. Yes, we do prescribe ADHD medications. Stimulants work fast, but they have abuse potential. And as you know, well, you might not know at this time, there is sometimes where there is I'm trying to think of the right word. They're lacking the amount needed currently right now in the pharmacies. So I'll have a lot of members who come to me and say, hey, that's not, they have to order it, it's on back order, because the demand is high. I don't know if it's like the product and demand, what's going on, but it can be hard and challenging, especially when, a member starts on a med and then they're like, hey, I don't know, like this stimulant, and I have to be transparent with me. I'm not 100, I'm still like learning and growing with the thoughts of like adding stimulants and how they work in the body, and the release mechanism and how long, and all that stuff. So that is a big thing. So stimulants, again, work fast, but it has abuse potential. So if you're dealing with populations that might have a history of substance abuse, that might not be your first line of first choice for ADHD. Again, that's when we'll go further along the way and talk about like what's important in like interviews, what you need to know, what is so important, what can help you, some things that are overlooked. But when you talk about non-stimulants, they may take longer, but they're safer. So non-stimulants might be a medication called Strattera or Wellbutrin. Caution with Wellbutrin, just a tip. Wellbutrin can actually lower the seizure threshold. So a good question that you might want to ask someone before you start that, do you have any histories of seizures? While you're doing your intake and you're talking about the medical history, usually ask about seizures or any other things that might have gone, or cardiac issues. If the member says, hey, yes, I have a family history of cardiac issues, I have cardiac issues, you might want to stay clear of a stimulant, not necessarily, but I always say, hey, I need a yearly EKG. I need to coordinate with your primary care provider to assess whether this is appropriate. Does the benefits outweigh the risk of taking this? I need you to sign and document that you are aware of the risk of this. Again, documentation is big. I know it might sound like kind of cold, but documentation is big. You want to educate your patient. You want to let them know, hey, this, here's some other options. And if they decline that, at that point, you can determine if you're comfortable with it or not. But documentation is key. Okay. So some books are a little more challenging. I felt like a good book that they have recommended in school was Stahl, S-T-A-H-L, Essential Psychopharmacology Guide. It makes complex concepts super, I guess, digestible for some people. For me, what I found was, I don't know if you can see that, but it's the Medication Fact Book for Psychiatric Practice, the fifth edition, the Carlot Publishing. So it was very helpful along the way in my journey, like as far as like knowing the side effects. They have like even like little clinical pearls, like things that you want to know or you might not know, and it would be nice to know when you're prescribing this. They also have fun facts. They have the generic versus the brand name. They have little charts of like how would you navigate if the member has these symptoms, how should you start with the prescribing. So this book is really awesome. I'll try to pin it below. Let's see. So let's talk about now real-world application, case-based learning. In real practice, when you're prescribing, it's it's almost like a balancing out act, because you're not only balancing effectiveness, you're balancing safety and also keeping in mind patient preferences. So let's go over some real world scenarios. Case 1. Patient comes to you, 28-year-old female with depression, reporting low energy and poor sleep. How would you handle that? What is the first thing that comes to mind? What else are you looking at in regards to her presentation? Are you, big key thing, the low energy, okay? She has poor sleep. You might start her off with an SSRI, like a medication called Zoloft, because it's well tolerated and effective, and you usually can start low, maybe 25 to 50 milligrams. You might even decide, hey, what's the difference? Maybe I'll do Lexapro. There's in the same category. And SSRI, also, just to let you know, is short for selective serotonin reuptake inhibitor. Okay, so again, it's so important to know the mechanism of action with the medications, but it's also, when you're starting slow, know what it's used for, and know like some of the things that might be affected when you have that member put that into their bodies. So some potential side effects. Always, my thoughts is that when you start a medication with someone, you need to warn them about the side effects, because sometimes they'll come back and say, oh my gosh, I had an allergic reaction. You'll say, well, what happened? I had a headache, my GI ups, I was having GI upset consistently. I can't tolerate that medication. It'll be after a couple days. They'll still call back and say that. Usually, it's that kind of hinders them from wanting to continue on with the medication, so then you don't really have a baseline as to whether the medication works or not. So it's so important to say, hey, I'm prescribing this medication. No, you don't have to list all the side effects, but the common things that come along with any antidepressant: GI upset, headache, possible dizziness, possible sedation. You want them to let them know, and also let them know that a big thing is that the onset, the therapeutic, the delayed onset of how it works, it may take up to 4 to 6 weeks for them to see some relief, and that is with titrating the med, increasing the med, going slow. If you're not sure which method to choose, I would say, again, the Carlot book that I just showed you, awesome, but also the Prescriber's Guide. Check out the Prescriber's Guide for Stall. It gives detailed guidance on dosages and side effects. It tells you what to look out for, lab tests that you might want to run when the patient is on a certain medication. So I want to cut this short, because I know that the attention span is not always there, so I'm going to cut it a little bit shorter. So, and then we'll pick up where we left off after this one last case. So case 2, managing anxiety with benzos. So you have a patient who comes into you, he's 45-year-old male with generalized anxiety disorder and a history of alcohol use disorder. So 2 things that pop up in my mind is a benzodiazepine such as Xanax, Ativan, Klonopin. That's a CNS depressant, so it's a central nerve depressant. Alcohol is also a depressant, so it's important to avoid benzos in that case. Instead, consider something such as an anxiolytic like Buspar, which is non-controlled substance, or again, an SSRI like Lexapro or Zoloft or something like that. It may take a little bit longer to work. It won't be as potent, but it will help them without having the misuse potential or the habit-forming potential associated with it. You always want to educate the patient that non-benzos take longer to work, but they're safe for long term. Again, a big thing is with benzos is memory loss. There's research studies that says that it has led to dementia or Alzheimer's, cognitive impairment. That's how, some people, they will drink and they will take a benzo to drive, not realizing it's very serious. So you want to know your member, you want to feel comfortable with what you're prescribing, and if there's a history of misuse, you don't want to give them free range to have something like that. And if you do have them on a medication like that, you want to manage it appropriately and follow up with them appropriately to ensure that they're using it and not misusing it. So in the next videos, we'll talk about treating bipolar disorder, treating psychosis, ADHD, and we'll think beyond the medication. So take care, be well. If you like this medication, if you like this video, please subscribe, like, comment below. Tell me something that I might have missed, or something you want me to elaborate on, or something you might disagree with. But this is just a basic video to kind of help. Okay, bye.